She will talk about the role of 20 in veterinary medicine emergency, critical patients. Welcome, Amy, back, and the stage is yours.
Awesome. Thank you so much. I know it's early morning, so I appreciate you guys being here. If you weren't here yesterday, I apologize that I am a fast American talker, and this is me slowing down. So my email address is there. If you ever have any questions, just reach out to me. Because we weren't able to get to my last session last night, I'm going to talk a little bit about stabilization and put it in here, but Dr. Byers is going to talk about fluid therapy later on this afternoon and really help you out. So what is the rule of 20? Well, we really have Rebecca Kirby to thank for it. She's a diplomat in both emergency medicine as well as internal medicine. And I don't know how many years ago, it was probably at least 15, maybe longer years ago, that she wrote Kirby's Rule of 20. At that time, she believed that critical care cases really needed 20 important things for us to really look at and figure out whether or not this patient was stable or was going to, recover. And so looking at these 20 things on every single patient that's critical, that comes into the emergency room, is really important, whether they're hospitalized or whether they're not just even getting admitted. So I kind of wanted to dive into the rule of 20. It's these things that we're going to take a look at a case, and then we're going to dive into each one of these and how they pertain to that particular case. But when we can take a look at these 20 things, if we're able to assess these 20 things in all of our patients are probably going to do a lot better, particularly when they're in our hospitals. So we're going to meet Brownie. That's not an original name in the United States. Pretty much almost every chocolate lab is Hershey or Brownie or something to that extent. So he's male neutered. He's 5 years old. He weighs 26 kilograms. He is a chocolate lab. And he presented for vomiting and hematochezia, so some bloody diarrhea. And this is his presenting physical exam. His heart rate is 180. Hopefully a lot of you are like, that's not normal, and I'm concerned about that. He's panting, but he doesn't have any respiratory effort. If you were listening to me yesterday and I talked about doing a RAP for triage, so respiration, alertness, and perfusion. We think about respiration, we're like, okay, we're not worried about that. But the perfusion is certainly something we're worried about. He has hyperemic mucous membranes, meaning that they're very bright pink. His capillary refill time is less than 2 seconds. His pulses are good. He's a little bit quiet because most chocolate labs are crazy. And he's not crazy in our ER. He has a painful abdomen. When we touch him, he winces a little bit. He's dehydrated about 5 to 8%. And his temperature is, and I converted it to Celsius. I prided myself as an American. This was very tough. 37.1 degrees Celsius. So yes, I tried very hard to convert all units for you, including the blood work values, which we'll see later on. Hopefully I did a good job. So that's his presenting complaint. So there's definitely some things that we're concerned about, right? We've got a dog who's been vomiting and has some bloody diarrhea, is a little bit quiet, obviously tachycardic. But his pulses are good. His gum color is very bright pink, So we've got kind of some mixed things going on. When we take a look at his diarrhea, because of course his owner brought it in, it's very bloody. It's bright red blood. All right, so when we look at the rule of 20, these are some of the things that stick out to me that I get concerned about. What's his fluid balance? What's his colloid osmotic pressure doing? He's dehydrated. What does that look like? What's his oxygenation and ventilation? That one I'm always concerned about. It turns out he's breathing fine, so I'm not too concerned. Do we have a blood pressure yet? What does that look like? We should probably take one. What's his heart rate? We know he's tachycardic, but he has good pulses, so it seems like he's got some good contractility going. Temperature we took is, a little bit on the low side, but it's certainly not too bad. But I'm concerned with fluid losses, and so what is his electrolyte acid base doing? His mentation and attitude is quiet, so I'm concerned about that. I'm always concerned about red blood cell hemoglobin concentration, particularly when we have blood coming out of the rectum. Gastrointestinal motility, that's a big one. Dogs in their GI tract, right? And then I'm concerned about pain control because ultimately I go to touch his belly and he goes, "Ooh, that's painful." So we definitely want to talk about that. So So fluid balance is determined by a lot of things, right? It's not just about one particular thing. When we look at assessing the fluid balance of our veterinary patient, we think about things like, what's the blood work doing? We don't know yet. What's the blood pressure doing? We don't know yet. We do know his heart rate, rhythm, and contractility, so he's got 180 beats per minute, normal sinus rhythm, and good pulses. His mentation is quiet, though, right? So we're a little bit quiet, and we're concerned about that. So we take a look at all of these things because your fluid balance is going to help determine what those things look like. So some general rules of stabilization. We really do focus initially on fluid balance and colloid osmotic pressure. And so that means, if you were in my last lecture, or my lecture yesterday on hip by car, you know you need an IV catheter. We don't need to do anything other than think about just getting IV access because we can't treat this patient, pretty much do anything with this patient until we get an IV catheter. I'm a huge proponent of drawing blood at the same time. You don't need to pre-flush catheters. In the United States, some people believe that you have to flush your IV catheters ahead of time before placing them, and you do not need to. It counts as a fresh stick, so as soon as you place that catheter, draw blood immediately off of that catheter. You can get up to 4 to 6 milliliters of blood, and so you don't have to re-stick your patient, which is really nice. We're going to think about fluids, and then obviously we also want to think about pain medication in this particular patient. And so what do we particularly think about, that fluid therapy per se? How hydrated is our patient? And we can determine that through mucous membrane color, obviously, skin turgor, so we're going to pull up, and if there's not a lot of elasticity, if the skin doesn't bounce back, I definitely think this patient's dehydrated. And the body weight of this particular patient. Now, in our patients that are hospitalized, that are on intravenous fluids, we want to ideally weigh them at least once, maybe twice a day, because we know that 0.5 kilograms of weight gain is usually equivalent to 0.5 liters of fluid gain or loss. And so depending on Brownie, obviously Brownie came in dehydrated. We want Brownie to gain some weight throughout his stay at our hospital because he came in dehydrated. We're going to go ahead and give him some fluids. We sure hope that Brownie gains weight. This is particularly true with our parvo puppies, right? Parvo puppies come in very dehydrated, some of them more than others. We want our parvo puppy to gain weight. But if we're losing fluids through vomit and diarrhea throughout the day and we're not keeping up with demand, parvo puppies in a hospital will continue to decrease weight, which tells me I'm not keeping up with the demand. So we want to watch, obviously, for evidence of edema and effusion, and we want to make sure that we note the losses of fluids. So every time, if we think we lose 20 mils of fluids in, say, diarrhea or vomit, we have to replace that. That's fluid loss that we have to calculate out. And sometimes it's pretty impressive, right? Bloody diarrhea can be very impressive by the amount of fluids coming out the backside. And you think, my goodness, there can't possibly be anything else left. And then there is. And you're like, my goodness, this is why I went into vet med to clean up diarrhea. So we want to think about doing blood work also to really assess what Brownie's doing, right? So he's obviously in an early, potentially moving into a decompensatory stage of shock. He's still walking, his tail is still wagging, but it's a low, sad wag, right? He's not doing that great. He's feeling a little sick. His heart rate is elevated. And elevated heart rates, one of the things that I've learned over the 20-something years of being in emergency medicine, they're not great. They definitely make me a little nervous, but I'm much more scared of a low heart rate. And so a high heart rate tells me that this heart is trying to compensate for the fluid loss. It tells me there's something that's not right in the body, and the heart is trying to keep up with the demand. When we have a low heart rate, a bradycardia, now the heart can't keep up with the demand. It's starting to fail on you. And so one of the things that I always say is nothing dies of a high heart rate. Nope. It always dies as a low heart rate before it goes into a systole. So you can always tell what level of degree of shock your patient is based on the fact that if they're still in a tachycardic state, their body's trying really hard. But once they move into a bradycardic state, their body's giving up, it can't keep up with the demand, and you need to work even faster. So we want to really do check to see, what is the blood work doing on Brownie, right? So we're going to get 4 to 6 mils of blood, and we're probably going to put it in all the tubes. That's what I always like to do. Throw it in all the tubes, because even if you think, I don't need to worry about clotting factors, I don't think Brownie has a clotting disorder, why would I need to run a PT or PTT? Maybe in an hour from now, something's going to happen, you're going to go, I want to run a PT, PTT, and then you already have that blood work, right? So the most common things that we're going to run is that packed cell volume, that hematocrit, the total solids, sometimes people call it total protein, the complete blood count, the CBC, the chemistry, and then venous blood gas. I don't really think about a lot of times running arterial blood gases, except for in a patient that's hospitalized and experiencing respiratory distress. I think arterial blood gases, probably in the course of a week, I run maybe only a few. Most of the time, I'm looking at venous blood gases. And venous blood gases can talk to us about lactates and well as glucose and electrolytes and those things. A urinalysis is never a bad idea, right? Make sure that we don't have like a urinary tract infection causing bloody diarrhea, which sometimes can happen. And then a pancreatic test, right? Because dogs are prone to pancreatitis, so running a PLI is never a bad idea. So we do want to obtain a blood pressure at this point, right? Brownie's come into the hospital. Brownie's kind of quiet, but tachycardic, but pink gum color and good pulses. And we decide to do a Doppler, right? We have a love-hate relationship with this machine. We get 90 systolic. Now, arguably in veterinary medicine, we still struggle with what is real hypertension versus hypotension. But there is a lot of merit in understanding where the blood pressure is with the patient. Understand this, though, blood pressure is just one number. And there's plenty of times that I don't believe the blood pressure. In the United States, when we are trained in school, they tell us to take 3 blood pressures and then figure out which is the average. To me, when I go into my doctor and I get like a routine physical, the nurse puts a cuff on my arm. She tells me to relax. I'm sitting down. She takes only 1 blood pressure. That's it, only 1. At no point does she say, I don't believe it, or I have to repeat it, or hang on, can you stop moving? There's a lot of factors in our veterinary patients, and I think in veterinary medicine, we have to not only look at the blood pressure, but if we have it available, look at the lactate, but also what is our patient doing? There are times where I've taken a blood pressure on a cat and I get systolically 60, but it's a cat that's lunging at me and wants to kill me. Do I think it has a blood pressure systolically of 60 at that point? No, I don't. So then I literally will say to my doctor, I don't believe it. I think it's lying to me. And so we have to look at just this, not only this number, but what our veterinary patient is doing. So blood pressure is complicated in veterinary medicine because the techniques and the tools that we have are not as consistent as in human medicine. So anyway, we get a blood pressure. It's a little bit low normal. I'll believe that because Brownie's quiet, right? He's a chocolate lab. He should be crazy in my hospital, and he's not. So here are some blood work findings. We've got a packed cell volume and hematocrit of 64%. Total solids, also known as total protein, is 9.2, so we are definitely dehydrated. We have a blood glucose of normal, hopefully that's normal in millimoles per liter, a lactate of 4.2. How many of you are running lactates in your hospital? Excellent, yeah. Lactates are very important. So lactate is a byproduct of an anaerobic production. So we are an aerobic species, so are most mammals, so meaning that all of our cells work on oxygen. Our heart cells, our GI tract, our muscle cells, every single cell in our body needs oxygen. And in the process of, unfortunately, illness or disease, particularly trauma patients, for example, blood doesn't flow to areas of the body that it should. And so, unfortunately, through, either distribution issues or maybe a lack of blood in the body, we don't get the oxygen to the cells we need. And one of the byproducts of that is called lactate. So lactate starts to build up during an anaerobic process. And the body will manage this to a good degree, but as lactate builds up, unfortunately, clinical signs also increase. And so one of the things that lactate does is it drives the pH of your body down. So pH should live between 7.35 and 7.45. But as lactate goes up, it pushes the pH down even further. You can have a normal blood pressure. I've had plenty of patients with normal blood pressure, meaning the blood is flowing around the body at a good number, but unfortunately the lactate is high. And so that's telling me that somewhere in the body is an anaerobic process where we see lactates really building up bloat. So gastric dilatation volvulus, right? That GDV patient, when we twist the stomach of a dog, unfortunately no oxygen's getting to that stomach. We will see really extraordinarily high lactates. And so our goal of fluid therapy is not only to improve blood pressure, but also to get lactate below 2.5. So 4.2 is high. That's telling me that unfortunately Brownie's working really hard, his heart is tachycardic, but there's somewhere in his body, and probably in the microvascular area, is not getting oxygen to the cells it needs, and so lactate is starting to build up. His pH concurrently is 7.30, not terrible, but it's also not normal. His bicarb, just a little bit low, albumin normal, and BUN is slightly elevated, right? So we basically are taking a look at this and going, he's not super critical, but we certainly want to be concerned about Brownie. So we're going to give him a fluid bolus, right? We know he's dehydrated, so that's a good start. It's a good start to say, I've listened to his heart. He doesn't have heart disease. His respiratory center tells me that he's breathing okay. I'm not concerned about fluid in the chest at this time. But I do know Brownie's really dehydrated. Brownie needs some fluids, which is really important. So we replace the IV catheter, we give him some fluids, and afterwards, like I mentioned yesterday, after we give fluid boluses, we want to make sure that we recheck their vital parameters. Our heart rate should go back to normal, our blood pressure should go back to normal. We should recheck that lactate as well. So afterwards, after one bolus, his heart rate's 150. All right, we made some improvement. His lactate is getting down, so that's good. We're getting oxygen to the cells that weren't getting oxygen previously. And so maybe we consider doing maybe a half a bolus or another full bolus because he is pretty dehydrated. But fluid bolus is always a good place to start, especially when we're dealing with a dog with gastrointestinal issues, right? So we take a look at the things we've already checked off on this rule of 20, right? We've started to focus on fluid balance and colloid osmotic pressure. Oxygenation and ventilation, we don't really probably need to worry too much about that because we've determined just by looking at him and esculpting him, Brownie's breathing just fine. We've already know his blood pressure. We're focused on his heart rate, rhythm, and contractility. It's improving, right? We're getting into the normal range. We already know what his glucose is doing. We've taken his temperature. We know his albumin levels. We've already looked at electrolytes and acid bases, his mentation, his red blood cells, hemoglobin, and his renal function. But the other two things that I had highlighted previously, gastrointestinal motility and pain control, we have not addressed yet in the rule of 20. So what other diagnostics can we do? Again, those POCUS exams, right? It's never a bad idea to quickly put a probe on and go, there's no fluid. I certainly didn't hear any fluid when I listened to the chest, but let's really confirm that. And then after that, should we think about other diagnostics like radiographs or ultrasound, right? So TFAST, AFAST for that point of care ultrasound, but also maybe do some radiographs, really make sure, do we see a foreign body? It's a chocolate lab. They're known for eating all the terrible things. Probably the #1 dog, Labrador Retrievers, at least in the United States, are one of the #1 dogs of eating all the foreign bodies they shouldn't. I don't know why dogs eat what they eat. I'd like to think that cats, I have both cats and dogs, and I think that cats sometimes are a lot smarter than dogs because dogs will look at that and they'll say, that's a battery, I shouldn't eat it. And a dog will come by and go, I'm going to eat that. And you're just, why? What would possess you to do that, you know? I saw a dog who once ate 5 golf balls. Why would you eat golf balls? Like, you know, it's hard. It doesn't look like food. And the dog just goes, you know, I'm going to swallow these, 5 of them. I'm going to swallow 5. I'm going to make my owners pay a lot of money. I don't know why, but it often is very interesting. So yeah, do we need to do radiographs? You know, is that something we need to worry about? Or go for a full ultrasound, certainly. So we did a POCUS exam. Brownie has no fluid. We're very excited about that at this point. And so, are we concerned about clotting? He's bleeding, from his rectum. Obviously, bloody diarrhea is coming out, and it's frank blood, meaning that it is actual blood. It's not melena, where it's been digested blood. And probably not at this time. Does it hurt to do coagulation factors like a PT and PTT? No, you could certainly add that in. But we're probably not too concerned. He has no petechiations. He's got no, ecchymoses. He doesn't have any, retinal hemorrhage or anything like that. So we're probably not too concerned with him at this time. But one of the big things we absolutely need to be concerned with on the rule of 20 is, what is the gastrointestinal tract doing, right? So the gastrointestinal tract is one of these interesting things. It's really about what is the GI integrity. And one of the big things that we get concerned about in the GI tract is translocation of bacteria. This is probably the scariest thing in probably most dogs that are having vomiting and diarrhea, is, are we concerned about translocation of bacteria? So bacteria lives both inside and outside the GI or inside the GI tract. And what happens is the wall just becomes, unfortunately, thin over time, and we have a failure, and the bacteria starts to leak out and gets into the bloodstream, gets into the abdominal cavity, and now we have sepsis. And sepsis obviously is super scary, right? For me, as a veterinary technician, veterinary nurse, I like a good sepsis case. That's my job, is to monitor this patient, be there for this patient, do all the really cool stuff, put in all the lines, let my doctor freak out about all the crazy blood work values and how norepinephrine is not increasing the blood pressure. That's for my veterinarian to freak out, but I'm gonna probably sit bedside by this patient and really truly care for this patient. So I like a good septic patient. I also like a good trauma patient as well. But translocation of bacteria can occur whenever we start to really wear down the mucosa of the GI lining. And when we're dealing with bloody diarrhea, think about what bloody diarrhea is. It's not just, a little bit of inflammation of the GI tract. We've essentially upset the GI tract to the point where blood vessels are rupturing inside the wall of the GI tract, and the dog is pooping out actual red blood. That's pretty significant. And if we let that go on for too long, that GI tract lining gets thinner and thinner, and then unfortunately bacteria can leak into the abdominal cavity. We're obviously worried about ileus. Ileus is where we see a decrease or complete cessation of the actual intestines from moving. We know that intestines are always moving. They're always kind of, contracting. And ileus, unfortunately, is where they become very flaccid. They start getting dilated, unfortunately. Dehydration. Obviously, Brownie's got some good dehydration. And then disseminated intravascular coagulopathy. We think about that, whenever we think about sepsis. So we start thinking about coagulation disorders. Now, Brownie isn't that sick, so my brain tells me I probably don't need to worry about too much, but I do need to make sure that translocation of bacteria doesn't happen, right? We don't want that to happen, and we do that through a couple of things. So one of the things that we're going to focus on is albumin and oncotic pulse. So this is one of those rule of 20s that we always have to look at. What is the albumin doing, right? And so albumin is wonderful because it makes sure that we don't look like Jell-O. Jell-O dogs and Jell-O, I don't know if that translates well, but they look like blobs, right? Like this is where fluid has unfortunately not stayed in the spaces it's supposed to, and we start to see fluid leaking outside of the space. And as such, they start to get puffy faces, edema in their arms, fluid in their abdomen or their thoracic cavities, unfortunately, and they get really sick. So albumin is the thing that holds all of those fluids in that space. And without albumin, we'd look like this dog and be way less cute, right? So albumin's super important in every disease process. This is why Rebecca Kirby writes about it in the Rule of 20. We need to know what the albumin is doing, and we need to make sure we keep track of it. And one of the ways that we lose albumin is when we stop eating and we start pooping out blood. And so in this dog, while I'm not concerned about the albumin yet, we need to make sure that we are appropriately treating this dog, or we might start to lose albumin. We start to lose it, especially, again, when they don't want to eat, and he's not necessarily eating very well. So excessive bleeding, I highlighted that because, again, we have to recognize that hemorrhagic diarrhea is in fact bleeding, right? You are losing blood to some capacity. Malnutrition, disease, sepsis is a big one. proteinuria, and then any sort of like gastrointestinal disease where we're losing protein, and certainly again, you're losing protein whenever we're pooping out blood and we're not eating very well. So I'm not sure if you have access to human serum albumin, but it's something to think about in your low albumin patients. And typically we reach for it usually when it, and I can't, the values I can't calculate that fast, but it would be 1.5 or less on the human American scale of albumin. I don't know if that translates well or not, probably not, for it's not the same. No, it's not. So we usually tend to think about it in patients that are really starting to show that they have a decrease in albumin. So it's used in both dogs and cats. Dogs and cats typically don't have antibodies that recognize the first treatment of human serum albumin. And interestingly enough, in human medicine, because they don't usually use synthetic colloids, because we talked briefly, though Dr. Byers will talk more about synthetic colloids this afternoon, things like hetastarch or hydroxyethyl starches, in human patients, they're cited to cause clotting disorders and renal failure. So then the question is, how do we get our colloid osmotic pressure up in human beings if that's what they're struggling with? How do we increase that? And the answer is albumin. They will literally reach for albumin because albumin has a colloid osmotic pressure of 200 millimeters of mercury. And to put that in perspective, a bag of hetastarch only has 33. So if you want to influence colloid osmotic pressure, albumin is the way to go. Unfortunately, in veterinary medicine, this product tends to be difficult to find, and the first transfusion does usually go well, except roughly about 10% of dogs actually do have antibodies already made for human serum albumin, even though they've never received the product. So I always say we give this product when we're really sure that we have to give this product. It's not that common that we do it, and it's, again, usually looking at a dog that unfortunately looks like this, where the albumin level has gotten really low, and we're struggling with albumin and colloid osmotic pressure. That's when we would reach for this particular product. We can only give this product once, because about 4 to 6 weeks after we give it, they build up antibodies to it, and that's it. It's one and done, basically. 25% human serum albumin is what we focus on, and like I said, colloid osmotic pressure has a weight of about 200 millimeters of mercury, while hetastarch, hydroxyethyl starch, only has 33. So again, if you want to influence colloid osmotic pressure, this is definitely the way to go. They do make species-specific albumin. It is backordered an awful lot. Can you guys get species-specific? It's basically like the unicorn of albumin. It comes lyophilized, so it's freeze-dried. It can just sit on your shelf. You reconstitute it with 0.9% sodium chloride and Normar or 5% dextrose, and you just have to use it within 24 hours. There should be no reaction. The company who creates it in the States is Animal Blood Resources International. And because there's no antibodies attached to albumin, you can do multiple transfusions. You do not need a filter. It will absolutely work to increase their colloid osmotic pressure and albumin, which is great in dogs that are losing tons of protein. These bottles have an expiration date of 3 years. Unfortunately, it is a struggle to get this product in the United States. It's been on the market for about 10 or 15 years. And this stuff it's honestly like liquid gold in my opinion. Because when you have a patient that's really starting to look like that black lab with the jelly face, unfortunately, this is the thing that's gonna correct that very quickly and do it the safest. So the other thing we want to focus on certainly is electrolyte and acid-base balance. You know, potassium probably is the most common electrolyte to have a disorder. So one of the things I always look at is what is the potassium doing in the electrolyte stage? It likes to go high or low for multiple disease processes. We want to check our values once a day. So I would say that most of our critical patients, you know, anything that has a difficult disease process like vomiting or diarrhea or kidney failure or anything like that, we tend to do electrolyte and acid-base balance at least once a day. That's the easy thing. If they're there for 7 days, we do it 7 times and just really make sure that the electrolytes and that the pH is behaving itself. You know, buffering system can become decreased, adding to the acidosis, and how do we lose bicarb? Through diarrhea and vomiting. right? So whenever we have massive vomiting and diarrhea, we start to lose bicarb. And bicarb is that thing that puts a shield around the pH and keeps it at 7.35 and 7.45. So if you lose your shield, your pH goes up or down and does crazy things. Other important electrolytes to include, sodium is probably a big one, right? Ionized calcium, phosphorus, magnesium, and chloride. Sodium and potassium arguably are the ones that like to do the strangest things in most disease processes. So definitely keep a track of those as well. We always want to know what the mentation and attitude is. And so how is our dog Brownie doing? You know, he came in quiet. I want to see that he's perking up. One of the things that you say as a veterinary professional as you get older, you say things like, treat the patient. You know, treat the patient, not the numbers. And so when we say that, because if your patient's blood work value looks terrible, but your patient's running around and eating and drinking and acting fine, well, then your patient's blood work values are probably going to improve. If your patient looks like garbage and its blood work values are fine, there's something going on. There's definitely something going on, and we have to investigate. And if it's not in the blood work, where is it? Is it on CT? Is it on ultrasound? We have to figure it out. Because sometimes we do blood work and we go, this looks really boring, but your patient is laying on its side looking terrible. There's something going on. You have to figure it out. So always treat the patient, however the patient's attitude and the mentation is of this patient, it's going to tell you how sick this patient is. The greatest thing about veterinary patients is they don't lie. People exaggerate symptoms all the time, right? Especially little children. I can't go to school. What's wrong? I stubbed my toe. It's broken. It's not broken. I can see it's not broken. But I can't even function. I can't walk. I cannot walk. Dogs and cats, they don't lie about their symptoms. They push through pain all the time. So the good news is if your dog is looking great, they're probably going to be fine. If your dog is not doing great, it probably needs something. Your patient's mentation and attitude should always improve. And if your patient starts to decline in the hospital, we need to do something differently. So perfusion parameters will dictate your fluids. And really, we think about, again, that perfusion parameters being focused on heart rate, rhythm, and contractility. So listen with your heart, with the stethoscope, perform spot check ECGs. And there's really these 6 parameters to cardiac function. Mentation's one of them, because if your cardiac function is bad, then your mentation is usually bad as well. The heart rate, the pulse rate, the gum color, capillary refill time, and the body temperature, all gonna tell you a lot about what that heart rate is doing. We also always, especially in animals that are losing fluid, focus on red blood cell and hemoglobin concentration, right? Brownie is pooping blood. Therefore, he is losing blood. That is what is happening with this dog. So we want to check that hematocrit and total solids at least once a day. So minimally, sometimes even twice a day in these animals. It's important to maintain a high red blood cell count and hemoglobin concentration, but we also want to watch for fluid overload and dehydration, especially if we're doing large boluses and high rates of fluid. So here's our update on Brownie. Okay, we're doing better. His heart rate has come down. We gave him a couple fluid boluses. We started him on a high rate dose of fluids because we want to replenish what he lost, but we also want to maintain him. He's got hematochezia still. His blood pressure is doing all right. He's still quiet, but he's brighter. He's brighter. He's realizing he's at the vet hospital and he doesn't want to be there. He's starting to act like a lab, basically. So we have to also think about renal function. You know, renal function's on the rule of 20 because it is so important. And recognizing is Brownie peeing is really important. Particularly when our parvo puppies come in, a lot of times they don't pee for hours. And we know puppies pee an awful lot. Normal, healthy puppies pee almost sometimes every hour, every couple hours. They're constantly peeing, right? Owners are calling us going, this dog will never be house trained. He's peeing everywhere. And you're like, it's a puppy. That's what they do. So parvo puppies, when they come in with massive fluid losses, they're so dehydrated, their kidneys will absorb every ounce of fluid you give them. And even though they've been on fluids for a couple hours, Their bladder hasn't made any urine because it's going back into the actual cells that were so dehydrated. So it's important, though, to make sure that Brownie is actually urinating. And we know his BUN was up, slightly elevated, and that's probably just because of the dehydration, but let's make sure that he's actually going ahead and urinating. Most acute abdomens, meaning painful abdomen, are at risk for organ dysfunction, so we want to keep that in mind. And we want to measure and quantify urine amounts, and we want to note it on the records. Don't forget to record the urine production. From a veterinary nurse standpoint, there's nothing that drives me crazier is I've come in, my other vet nurse is going home, they've worked 12 hours, I finally go ahead and I take a look at the record of this particular patient, and it says the dog has not urinated all day. And I'm looking at the dog, and the dog seems totally fine and is like doing okay. So now I have to call the vet nurse and say, hey, did the dog really not urinate all day? Because my doctor needs to know, like, did it really not urinate all day, or did you forget to record it? And they go, oh no, the dog's fine, just forgot to record it, right? So it is important to know if your pet patient is actually urinating, because the whole point of the kidneys is to make pee. That's its only job. If it doesn't make pee, it's broken. The other thing we need to obviously focus about is the immune status in antibiotic doses. So antibiotic selection should be based on the results of culture and susceptibility testing. Now, we don't always do cultures. We don't always submit them out to a lab. Sometimes we do broad spectrum, and in the case of things that might have translocation of bacteria, that is the case. But in a lot of wounds or things like that, pneumonia cases even, for example, we do want to do cultures. We want to make sure we put them on the right antibiotic. I mean, this is why, unfortunately, resistant bacteria to antibiotics is so prevalent. MERS is a real thing because, unfortunately, we just hand out antibiotics like it's nothing. Empiric treatment should occur, but really, if you are based on that data of what's common for that particular area, that's what we want to use. If it's something that needs to be cultured, then we want to culture it, and we want to make sure they're on the appropriate antibiotic. Obviously, with Brownie, we really want to focus on the gastrointestinal motility and mucosal integrity. What's his GI tract doing? Because unfortunately, if your GI tract shuts down, you don't live very long. You need your GI tract to fully functioning. So acute abdominal patients are at risk for things like gastric ulcers, ileus, gastritis, GI disturbance. And so is our patient eating? And Brownie came in not eating, which is very unusual for a chocolate lab, right? That's a crisis in and of itself. Is there any other vomiting or diarrhea? And all these indicate what is the GI health of our patient. Now, in Brownie, arguably, it's not very good. He's pooping blood out his butt, and that can't be very healthy for him. So we need to fix that, right? So we need to figure out how do we improve the mucosal integrity so we don't worry about Brownie going septic or having bigger issues. One of the ways that we stop vomiting is by giving an antiemetic. And these are our transmitters, and these are our receptors. And one of the frustrating problems of veterinary medicine is figuring out which one we're going to give, right? There are some times where we actually give multiple ones. So substance P, NK1, that's Serenia, that's meropitant, that's going to help with that one. Dopamine, you need a D2 dopaminergic receptor. Your 5-hydroxytryptamine, you need your 5-HT3 serotonergic. Acetylcholine, you need an M1 cholinergic to block. Histamine, H1 or H2 histaminergic. And norepinephrine, you need alpha-2 adrenergic. There's nothing more frustrating than you give it famotidine. You've given this patient meropitant. You even put in ondansetron, and it's still vomiting. And that's because we still have 3 other receptors we haven't even done anything with. And unfortunately, in veterinary medicine, we don't have the ability to have one drug that blocks all of the neurotransmitters and receptors from attaching. So that's why you get breakthrough vomiting. And that's why it's important to explain this to owners too, because owners get very frustrated. They say, you gave him a pill, you gave him a shot, you gave him something to stop him from vomiting. Why is he still vomiting? And the answer lies that, unfortunately, we might not have blocked the right neurotransmitter and receptor. So here are some of the drugs, obviously. We think about metoclopramide, Reglan. It's a D2 dopaminergic antagonist. Ondansetron, in the States it's known as Zofran. It's a 5-HT3 serotonergic. Famotidine, we know this as Pepsid in the States. It's an H2 receptor antagonist. And then meropetin, Cerenia, it's an NK1 receptor antagonist. Now, arguably, meropetin is one of those ones that works pretty early on in the emetic center. And that's why it's so effective, because it blocks substance P. And substance P is one of those receptors that gets tapped really early on to say, hey, you're about to vomit. And the problem with Cerenia, also known as meropetin, is it's a great drug, but it's almost too great. Working in an emergency hospital, there are plenty of times where, a general practice doctor will see a dog like Brownie, maybe just give it some sub-Q fluids, right? Give him some Cerenia and send him home. And now if Brownie decided to go ahead and eat a foreign body, because it's a chocolate lab, that seems reasonable to think that. They don't do any, radiographs or anything. They send it home. The problem is Brownie will stop vomiting, and the owners will believe that Brownie's doing better, and Brownie might even eat some food, because Cerenia, meropetin, works that great. But then the problem is that the food goes into a GI tract that unfortunately is already experiencing ileus, and it starts to rupture. And so the foreign body will poke through. Unfortunately, the foreign body will rupture the GI tract. And about 3 days later, when the Cerenia wears off, when the meropetin wears off, they come into the ER because Brownie's vomiting again. Isn't that strange? And now Brownie has sepsis, for example. So it's really important that when we give these drugs, particularly meropetin, we really make sure there is no foreign body. Because the whole point of vomiting is it's your stomach telling you there's something bad and you shouldn't eat. And so sometimes vomiting is good because it's an alert to say, hey, I'm broken, you should fix me. But when we mask it, when we pretend like you don't need to vomit, unfortunately, our stomach says, oh, I can eat now? And then, unfortunately, we can rupture a gastrointestinal tract. So it's really important when we give these drugs, we make sure there's no foreign bodies, because the amount of foreign bodies that have perforated, that have caused sepsis, because we blocked the vomiting receptor, which is great because the dog's not vomiting, but it needs to be vomiting because it actually is telling us, I'm not okay. So think about that. Make sure you rule out things like foreign body. So Brownie, arguably, we've decided doesn't have a foreign body, which is great. So we can go ahead and try to stop the vomiting in Brownie, hands down. The other thing that, the rule of 20 always talks about is, just remembering your drug doses and the metabolism. How do drugs interact? Making sure that we are methodical at the drugs that we give. Critical patients usually are receiving lots of medication. And does anything interact with each other? I don't know if you have in your hospitals like a drug interaction chart. Does anybody have drug interaction charts? There's a couple available online. They're usually gigantic. And you basically will read down and you'll see meropetin, and then you can go over and see what other drugs it should not be given with. Those are really helpful. Otherwise, if you're not familiar with that particular drug, you should go to a drug formulary and review, is this drug allowed to be given with this drug? Because drug interactions unfortunately occur when we don't know if they can be mixed together. We want to record always the medications that we give and when we gave it. And there's these 5 R's. These 5 R's are very important. Arguably, I take a little bit of liberty and say it should be 6 R's. And so in the United States, we talk about the right dose. It needs to be the right dose, the right drug, the right patient, the right route, the right time. And now I'm going to say also, write it down. Because there's a lot of times where we just like to yell out drug orders and go, give meropetin, 1 milliliter, and you never write it down. So writing it down is really important. We're in a strange profession because in human medicine, that's not allowed. You have to write everything down. Just don't think about and give it to the patient, because then someone could else come along and give it the same thing. Drug mistakes are the #1 issue in veterinary medicine when it comes to medical errors. And the reason why medical mistakes occur is because we're not thinking, we get busy, and we're human. So over and over, make sure that these things are correct before you give medications to your patient. NSAIDs, right? So non-steroidals absolutely is a no when anything has a gastrointestinal issue. It's just a no. NSAIDs, and it probably should also repeat up here, steroids, right? No steroids, no NSAIDs. So NSAIDs inhibit the bicarbonate secretion and can injure gastric mucosa. We're very concerned about Brownie's GI tract. He's pooping blood. That's not normal. The owners are freaking out. They're like, he's pooping blood. Is he dying? And you're probably like, probably not, but it looks very scary. So NSAIDs and steroids are an absolute no. They are not kind to the GI tract. And so now let's go back to our rule of 20, right? Look at all the stuff we've already done with Brownie, right? We've done fluid balance, colloid osmotic pressure, oxygenation, ventilation. He's fine. Blood pressure, we've got that improved. Heart rate, rhythm, contractility. His heart rate is almost within normal limits. Glucose is fine. Temperature, albumin, we're not worried about yet. Electrolyte, acid-base, mentation, attitude, and hemoglobin, all those seem okay. We've talked about, and we're focusing now on gastrointestinal motility, right? Maybe we give him a broad-spectrum IV antibiotic in hospital to make sure that he doesn't have translocation of bacteria. We give him an antiemetic. We've talked about renal function, his clotting ability. I'm not concerned with it at this time. We've talked about that antibiotic dosage, making sure that we don't overdo it and we pick the right ones. Drug doses and metabolism. But we still have these other things that are pretty important to go over, right? Pain control is really big. So sometimes our patients with abdominal pain come in, and let's see if this will play here. Make sure my sound's all the way up. All right, here we go. Right. So the thing about the stomach is that it has a unique set of pain receptors. We know this to be true because if any of you have ever had a lot of gas in your stomach or in your intestine, it hurts. Have you ever been doubled over in pain where you can barely walk because of gas? It's just gas, your stomach's out to here, you don't feel good, and you're just like, oh, right? That hurts. Now imagine pooping bloody diarrhea and your stomach wall is completely inflamed as well. It's going to hurt. The reason why the stomach has a heightened sense of pain receptors in it is because it's a protective mechanism. Without food, you do not live. And so when your stomach is sick, it wants to tell you, I'm not okay, and I'm going to cause sharp shooting pain throughout your entire body to the point that you can't walk, that you're screaming like this, and you need to do something because I am pretty important. So that's why the stomach always has an exaggerated pain receptor, because it's trying to tell you that, hey, I'm not all right, you need to do something about it. It hurts way worse than sometimes I think breaking a body part, because it's so painful when you have a gastrointestinal issue. So almost all critical patients need some type of pain management, right? Being sick is not fun, but especially when you have like a painful disease process that has to do with the gastrointestinal tract. When we think about moderate to severe pain, we think about opioids, right? Maybe some methadone, maybe some fentanyl, heavy-hitting drugs. When we think about mild to moderate pain, codeine, tramadol, question mark, right? So I don't know, do you still give tramadol here, or? Yeah, so tramadol is one of these things that, 10, 15 years ago when we started using it, we thought it was great. And then some data published studies came out and said, it probably doesn't work as well as we think, or if it does, it has to be a significantly higher dose. So I think there's mixed reviews on tramadol right now. We're throwing gabapentin at everything. Are you throwing gabapentin at everything? Yes, everything gets gabapentin. Trazodone as well in the United States. We want everything sleepy before it comes to the hospital. So it's crazy because I think we don't know that much about gabapentin, and it's much like tramadol. When tramadol came out, we were like, everybody gets tramadol. It's this great drug. And that's how we're treating gabapentin. Give it 5 or 10 years, and we're going to reevaluate gabapentin. But right now, everybody's getting gabapentin. And then certainly Buprenex is kind of on that lower pain scale as well. Nutrition. Listen, the thing that gets your GI tract feeling better is actually food. Isn't that ironic, right? We think about wanting to stop the food, and that's okay for a brief period of time, but I went to a lecture at IVEX, probably like 6-7 years ago, and it was by a boarded nutritionist, and this is what she said. She was challenging people about parvo puppies, because textbooks will tell you that every time an animal vomits in a hospital, you have to wait another 8 to 12 hours before you reintroduce any food. And her point was that parvo puppies are always vomiting, even just a little bit. And she said, listen, what I advocate is put a feeding tube in them, and if you can get more food in them than they're vomiting out, you win. And I went, she's right. Like, if you can get more food in your patient than they actually vomit out, you do win that battle. And so we have to think about nutrition, that every disease process gets healed because of nutrition. There isn't a disease process that we really want to hold for too long. And yet our veterinary patients, particularly cats, owners come in and they'll say things like, you know, he hasn't been eating for 2 to 3 days. And we go, oh, okay, like that's normal. If I didn't eat for 2 or 3 days, I'm pretty sure I'm dying. Like that's not normal. I love food. And so they go, oh, he hasn't eaten for 2 to 3 days. And we go, okay. Then we hospitalize the cat. And inside the hospital, do cats eat? No, they do not. So now it's been another 2 or 3 days. It's been a week. We don't even blink an eye. We just go, all right, well, maybe one day the cat will eat. We have to figure out ways of getting our veterinary patients to eat. Sometimes considering feeding lines, right? In Brownie, I don't think it's really necessary. He's only had not eating for 24 hours. He's a lab. He's usually got a high food desire. I'm sure once we get his GI tract feeling better, we stop that neurotransmitter and receptor from connecting so that he doesn't vomit. Brownie's going to go right back to eating everything, right? That's what Brownie's probably going to do. But in some of our veterinary patients, septic patients, parvo puppies, renal disease, absolutely think about, can we get a feeding line in them? Do not force feed your patients. This is where we pull fluid into a syringe and then we open up their mouth and we squirt it in. That's like drowning them. That's a terrible, must be a terrible feeling. And also, it develops food aversion. It's like a Pavlovian response. So every time I now see food, I associate it with the pain of someone injecting it in my mouth and causing me undue stress. So we have to get our patients to eat naturally, or we think about feeding tube options. We don't do force feedings because it can result in aspiration, unfortunately, and it's also, I think it's a form of torture. I used to do it years ago because that's what they taught us, but now data and science has shown that it actually results in food aversions, and then they don't want to eat, and then you have a harder time getting them to eat. So Brownie needs a bland diet. We all know how to give bland diets, right? We have to instruct owners, however, to give bland diets, because owners go, oh, I know what a bland diet is. It's McDonald's, right? Like isn't that a bland diet? And you're like, no, that's not a bland diet. But I can get the chicken from McDonald's, right? And just no, it's not the same. So boiling chicken separately from the white rice. Why do we boil them separately? Because the white rice will hold on to the fat of the chicken if we boil them together, and that defeats the purpose of boiling the chicken because we want to strain the fat off. So owners need to be taught how to do this. Handouts are a big thing. I like still physical handouts because even though we're so glued to our phones and even though we love technology, here's the thing, we're human beings, and if I don't physically see something, I forget about it. And our phones, we've got 1 million emails. If anybody in this room doesn't have emails in their email inbox, you are my hero. Because my inbox on my email is like 100 emails. I'm never going to get to all of them. I try very hard to keep a list of things I'm supposed to do in my email, but it's chaotic, right? I don't know anybody who doesn't have emails in the inbox of their email, right? And so we get very blind to that. But physical handouts are great because when you give an owner a physical handout, they're going to take it. They're going to do what everybody does. They go home and they throw it on a table. And then later on, when they go, oh, I've got to feed Brownie a bland diet, they're going to walk by and they're going to go, oh, there's the handout, and now I can read it. And that's going to be a lot easier for them because otherwise they go to Dr. Google, and Dr. Google is wrong a lot of times. Dr. Google says crazy things. So definitely instruct your owners how to do a bland diet. Now, one of the rule of 20 is focusing on wound care and bandage change. Now, Brownie doesn't have any, obviously, wounds or bandages, but if he did, they would need to be addressed. So we can usually skip over that one fairly quickly, but certainly wound care and bandage change is on the rule of 20. So the diagnosis is acute hemorrhagic diarrhea syndrome, which was also known as hemorrhagic gastroenteritis until the last couple of years. You'll see both of these referenced at this point. So super smart doctors decided to change the name because the key is it really gastroenteritis, or is it just something from the large intestinal tract? And so therefore, this is a more accurate term. It's not as fun to say, though. Acute hemorrhagic diarrhea syndrome. In the United States, saying HGE is way easier. This doesn't flow off my tongue, so that's what Brownie gets diagnosed with. So it doesn't seem that complicated, but when we look at all the complexity of things that could go wrong, this is why it's so important to always look at that rule of 20. So nursing care is really important as well. And so, in the United States, again, we have veterinary technicians, also known as veterinary nurses. And so I am the one who cares for this patient in my hospital. My doctor's gonna say, do some blood work, place an IV catheter, let me know what the heart rate's doing, and then they're gonna move on to the next case. So the success of critical patients is often lies in noticing details. Veterinary technicians and nurses, we pride ourselves in noticing the little details. Sometimes I might not know exactly why my patient's doing what it's doing, but I notice something different, and I'm going to call my doctor over, and they're going to help me out. We want to make sure we don't forget the obvious, and excellent nursing care is really key to making sure these patients do well. So it's things like turning the patient, in case of Brownie, fecal scald, right? Fecal scald is a very real thing when we're dealing with lots of diarrhea. Keeping patients free of urine scald and bed sores. Passage range of motion if these patients aren't moving. Bathing and cleaning is so imperative because listen, you might get Brownie feeling better, but if he goes home with a butt looking like that, his owners are going to be mad at you. And you have to bathe them, not just wipe down the diarrhea. You have to get the diarrhea off of them. So cleaning up diarrhea is very important, and even though that's not why we went into vet med, it is one of the things. If you've not seen this, Mila makes a fecal catheter. So if you've not seen this in action, this is what this looks like. It is like an endotracheal tube. You insert it into the rectum. You go ahead and inflate the cuff, just like an endotracheal tube. Now, there's not a lot of data to say that you have to deflate and reposition the endotracheal tube, but we do that every about 4 to 6 hours just to make sure that we're not going to cause necrosis of the mucosa of the large intestine. And then it collects it into a bag, which makes your life so much easier. Because if I could get back the countless hours of cleaning up diarrhea in my career, I would have a lot of time, probably years of my life back, because there's a lot of diarrhea cleaning up in the ER. I think a lot of people think emergency medicine is trauma, sepsis, high-rise syndrome cats, really cool cases. I would go with more than half of your cases are vomiting and diarrhea. That is the disappointing thing of emergency medicine is my dog has vomiting and diarrhea. You're like, here we go again. Oh my gosh. Please, can I send this one home? And when we have to admit bloody diarrhea, I can tell you from a veterinary technician standpoint, I sometimes think about being a doctor in that moment because my doctors don't clean up the diarrhea. I do. They go, good luck with that. Bye, Amy. And I'm like, no. So getting these catheters in are amazing, and they really do help the time that it takes to clean up animals from diarrhea. So let's look at this rule of 20. Man, we're crushing it. We have done all of these things except for this one. Tender, loving care. And I love that Dr. Kirby threw that in there because it's so important. It's the thing sometimes in veterinary medicine we forget about. We can't dismiss kindness and love in our veterinary patients. And the thing about veterinary medicine is we all went into this business because we love animals, again, usually more than people. And that's okay. We can say that because we're in veterinary profession. But the thing that we forget about is that we get so busy. We start seeing so many cases and we forget to just stop and pet the animal. That's why we went into this business, right? Sit next to your patient. Squish the cat's face who will let you scrunch it, right? A lot of cats are going to bite you. But a lot of them, sometimes you can pet them, right? But we get so busy and we have to get on to the next case and the rooms are filling up and we're super busy that we forget to just stop and take care of the pet and say, how are you doing? You know, I'm sure you all talk to animals like I do. This is important, right? So I talk to them like they're human beings. How are you doing? Are you scared? It's okay. We're going to get you better. We're going to get you home, you know? The nice thing about veterinary medicine is you can say anything you want to your veterinary patients and they can't tell the owners. So sometimes I say, your owners are jerks. You have terrible owners. Why do you live with them? Go find another house. You know, things like that. You know, or sometimes I say, you're very naughty and you're bad. Stop eating stuff. And they will never tell their owners what you have said to them. And if you say it in a nice voice, you know, that's the biggest thing. I tell my dogs they're bad all the time. I go, you're so bad. You're so bad. I am going to give you away. But I would never do that. But when they're naughty, I just say those things to them, right? So recognize that mental health of your patient plays a direct role in their recovery. If they are sick and depressed and they haven't seen their owners for days, they are not going to do well. Mental health of our veterinary patients is equally important. So pet them, talk to them, give them all the love they need. Tell them they're going to get to go home. Say words that they know, because happiness helps with healing. There's a lot of actual data and science in human medicine that shows that when, you know, particularly elderly patients in the ICU, when they get to see visitors from, you know, their loved ones, when they get to experience happiness, even if it is small in the ICU, they heal a lot faster. For anyone who had anybody hospitalized during the pandemic at the height of it in 2020 and you couldn't go see your loved one, that was not only hard on the people who couldn't see them, but it was very hard on the sick patients in the hospital because they felt like, this is scary, it's a pandemic, I don't know if I'm going to live or die, and I can't even see my family. So we need to allow owners of critical patients to come in. If you have hospital rules of visiting times, I challenge those, right? Hospitals should have some visiting hours, but allow owners to come in whenever they're able to come in because it's so important. So Brownie's treatment, all we really did was just give him a lot of IV fluids, crystalloids, right, over 36 hours. He was a pretty straightforward case, but the thing about Brownie is that those cases can trick you. And like I said, the amount of countless, you know, acute hemorrhagic diarrhea syndrome patients that I have seen in my lifetime, where general practices see a case just like Brownie, tachycardic, pink gum color, pulses are good, you know, they go, at the end of their day, they go sub-Q fluids, some meropitant, send them home. That's not going to cut it in those cases. He's hemorrhaging blood out his rectum. That is just not going to be good enough. And the problem is that they go home, and about 6 to 8 hours later, they're back in the ICU, and they look like garbage. And I've seen a few of these cases go septic because, unfortunately, we didn't treat them appropriately. So the rule of 20 is really great because it does tick off all the most important boxes in any critical patients. We gave him some metronidazole orally. We gave him some Unison just for about 24 hours. Then he stopped pooping blood. We thought his GI tract was doing better, and we stopped it immediately. We did a lot of hind end baths. That is the veterinary technicians doing that. Lots of diarrhea cleanup because we didn't have the Mila catheters at the time, so it was really great fun. Put him on a bland diet, and it seems simple, but what would have happened without intervention? Brownie probably would not get better because bloody diarrhea is honestly, it doesn't tend to improve upon itself. And subcutaneous fluids don't get absorbed fast enough or well enough to actually change a lot of the integrity of the gastrointestinal tract. When you're that dehydrated and you're still pooping out blood, you need IV fluids, which is really key. So you completed the rule of 20. So great job, team. So applying the rule of 20, any acute abdomen patient allows you to receive the patient to receive the best care, and understanding any sort of unique nursing care techniques is certainly going to offer best outcome. These are my two beautiful dogs. This is up in Maine, in the United States. That's Blitz, and he's a mini Aussie. He's my punk. Like, he's so fresh. He's the one I'm always telling he's bad. And then that's my most perfect border collie in the whole world. No one else has a more perfect or beautiful dog, so I'm sorry. But he's really lovely, and I love him so much. I love them both, but this one is not. He's so naughty all the time. So does anybody have any questions for me? No. They're like, she slowed down, and she still talks fast. Yes? So we give albumin, and I'm sorry, I can't do the conversion because I have United States metrics in my head. Usually we start to think about it once it dips below 2 on the American scale. So if you email me, I'll convert that for you because I don't know. Which is 20? Oh, okay. Okay, so 20. Usually below 20, then there you go. She knows. I don't. We use, it's the country with the weirdest metric system, or not metric system, but other units. So yeah, so that's when we start to think about giving albumin. And again, if you can get species specific, you could just give it because it doesn't have a lot of side effects. It doesn't have, they won't build up antibodies. The problem is no one can get it. So then we think about human serum albumin. We try to not give it though if it really goes below probably 15, okay, or even below 10, I'm doing good, then we're gonna start giving it, because human serum albumin you can only do once, and they have documented that roughly about 10% of dogs already have antibodies. So you could have a life-threatening reaction to human serum albumin. So if your patient's gonna die from not having albumin, and you're like, this patient is not going to live because it has low albumin, it's starting to look like that black lab, then you risk giving the human serum albumin. So you do everything else you can and try to beef up colloid osmotic pressure with maybe synthetic colloids, get food into them because food always increases albumin and protein. If we can't do that, then obviously that's when we go, okay, this patient is going to die. We've got massive fluid shifting. We have to do human serum albumin. Thank you on helping me with the conversion. I was like, damn my American numbers. You're using what?
Sorry?
Oh, so you do too? Oh, you're on my scale. Okay. Oh, so, all right, my gosh. Well, I'm glad I put all the units up there. So yeah, below 2, we start to think about it. Below 1.5, we're like, definitely below 1, we're like, we have to give it. Like, there's no question. So yeah, that's an easy conversion, by the way. Yeah. No, that's a really great question. I'm glad that you asked that. So can we just give plasma? And unfortunately, the amount of albumin in plasma, it doesn't affect the actual albumin levels in the body. They once did, there was some published paper that I saw that you need like basically 5 or 6 units of plasma in order to even start changing the albumin. There's just trace amounts in albumin in the blood itself. So it's not gonna, you need concentrated. So unfortunately, it doesn't really move the needle. But that said, plasma, fresh frozen plasma, is a colloid. And when we're talking about increasing colloid osmotic pressure, one of the things, at least in the universities and all the specialty hospitals in the States, in order to increase colloid osmotic pressure, just simply giving fresh frozen plasma will influence that. It won't have a direct influence on albumin, but it will increase the colloid osmotic pressure, which in theory should help to improve, basically the fluid balance that we're dealing with. So that's one of the things. Do you give fresh frozen plasma for just increasing colloid osmotic pressure? Yeah. So it's becoming more commonplace to do that, but it won't change the albumin. But if we can get the patient feeling better and eating, the number one thing that will increase albumin is food. It's definitely food. I'm always like, you need food. Food, protein, food. It will change all of this. So yeah. Yeah, so we don't use too much TPN. We use a lot more PPN nowadays. So that's total peritoneal nutrition or partial peritoneal nutrition. Most of what we use is just PPN because it can go through any line. But we use it, though not as commonly as we used to. I think because we're getting better with understanding the importance of nutrition. And we just place a lot of feeding lines, honestly. If the patient's excessively vomiting, then we'll think about maybe PPN, but we have to special order it. We can't make it at our hospital, so we got to order it from the university and then go and get it, and that's a pain. So, yeah. Any other questions? Yes. So in theory, they develop antibodies in, 4 to 6 weeks later. I've never given multiple bottles of human serum albumin. I think, it does take some time to develop antibodies. Usually it works really well and we get the albumin up. But have you done multiple transfusions of albumin? No. Yeah, just once. So that tends to be the good rule, is so that we don't have an anaphylactic reaction occurring to it. So yeah. Any other thoughts? All right. Well, thank you so much for having me. I really appreciate it. Thank you.
So our next session will be head trauma with Dr. Celine, and she will create some miracles to deal with head trauma. The stage is yours, doctor.
So good morning, everyone. Thank you very much. I will talk about the other extremity of the dog, so not the butt, but the head this time, and I won't be able to speak as fast as Amy. So I will talk about head trauma and how we can do the difference when we receive this kind of patients. Just for the introduction, as for any kind of trauma, the cause of the head trauma can be very, very different, and the importance and the gravity of the head trauma can be also very different. Never forget that most of the time when you have head trauma, you may have also other kind of trauma, so it can be a very, very multi-trauma patients. And most of the time also when you look at the literature, the dogs and cats with head trauma has a worse prognosis compared to any kind of other trauma. So this is quite a very impressive trauma. The owner are most of the time very impressed by this kind of trauma, and so this is where we can make the difference. Just to be clear about what I am going to talk, I'm going to talk about traumatic brain injury, so the TBI, which is totally different than the head trauma. So you can have a lot of head trauma, but you don't have necessarily a traumatic brain injury. What I mean is when you receive this kind of patient, so this is just the head of the patient, like this, you can see that this head is moving while this patient is breathing, which is totally not right. But when you look at this patient, he's normal, he's working in your ICU, he's totally interacting with you as normal, so he doesn't have any traumatic brain injury. It means that his brain is normal, but he has this kind of fracture of the sinus, or he can have any kind of fracture of the jaw, but this is not necessarily associated with traumatic brain injury. And on the other side, you can also have totally no fracture of the head, but you can have a traumatic brain injury. So I will talk really about the trauma of the brain and not of the trauma of the head. So I will go through a little bit of physiopathology because it's important to understand why we will use this treatment and where it will act. And when we have a traumatic brain injury, you can separate the traumatic brain injury between primary brain injury and secondary brain injury. For the primary brain injury, it's really what's happened when the patient has the trauma. And so this is the direct action of the trauma on the brain. And all the lesions that can happen as primary brain injury have been very well described. So you have different types of injury. The less important one is the concussion. So it means that you just have a loss of consciousness, but there is no lesions on the brain. And then the gravity increases when you go through this table. And you can have blood in the brain, you can have contusion, you can have laceration of the brain. And so with this primary brain injury, you can't do anything, and this is really directly the trauma that make the lesions on the brain. So where you will be able to act will be on the secondary brain injury, and this secondary brain injury occurs hours or days after the trauma, and your treatment can reduce this traumatic secondary brain injury, but your treatment can't do anything on the primary brain injury. So, and this secondary brain injury can also be reversible, so it means that your patient will improve, can improve with your treatment thanks to the improvement of the secondary brain injury. So this is really the focus of the treatment, to decrease and to improve this secondary brain injury, and this is where we can make the difference. So what happens when we have this secondary brain injury? When you have a trauma on the brain, you will have a lot of secretion of and release of excitatory neurotransmitters. So it means that you will have a direct damage of your neurons. And this release of excitatory neurotransmitter will lead to movements of calcium and sodium in the neurons. And if you increase the amount of sodium in your neurons, it means that water will go from outside the neuron to inside the neuron. So this is one of the explanations why we have this cerebral edema when we have a traumatic brain injury. You also have the liberation of a lot of inflammatory molecules, and that will, increase the lesion in the brain, and this is a circle that you have to break with your treatment. And so, because of these lesions, you will have this cerebral edema, and we know that a lot of things that happen in trauma will increase these lesions in the neurons. And in particular, hypoxemia. Hypoxemia is bad for the cells and specifically bad for the brain cells. Hypotension also is bad for the cells, and we will see why it's very important to maintain a good blood pressure when you have this traumatic brain injury. Change in CO2, so hyper or hypocapnia, is also will induce some change in the brain. Hyperglycemia also is bad for the brain, because you know that neurons don't have any storage of glucose. So if you have a patient with hypoglycemia, the neurons are not able to work correctly. And we also know that hyperglycemia is associated with a worse prognosis in this patient with traumatic brain injury. And every kind of acid-base or electrolyte disturbance will also change the way the neurons are functioning and will increase this secondary brain injury. So everything in this will have to be treated when you have to deal with this brain injury. And also what it's important to remember when we are talking about the brain is that the brain is in a rigid skull, so the brain is in a box. And so there is this Monroe-Kelly doctrine, so it was two medicine doctors who described the fact that there is a direct relationship between the volume and the contents of the cranium and the pressure in the skull. And so what do you have in this skull? So when we are talking about the brain, we know that the brain is in the box, the skull. And in this skull, you have most of the thing that is in the skull is the brain parenchyma. And you also have the blood, and you also have the CSF. And all of these normally should be stable and should be the same volume all the time. And so the intracranial volume is made by this association of the volume of the brain, the volume of the blood, and the volume of the CSF. And so why it's important to remember that these three structures are in this box? This is because there is a direct link between this volume, so between the intracranial volume and the intracranial pressure. And it's very important for the body to keep this intracranial pressure constant and normal. And so when you have a trauma or when you have a tumor in the brain, it will add something in this box. And so the volume of this the volume in the skull will increase. But there is a lot of things that will happen in the brain to try to keep this intracranial volume stable in order to keep this intracranial pressure stable. And so there is a lot of stuff that will happen. This stuff first is that the volume will stay the same. So when you have like a tumor or an hematoma after a trauma, it will if the volume of the brain increase, then you will have a decrease of the blood flow, or you will have a decrease of the CSF to try to keep this volume constant. Then there is also a very important mechanism to try to keep the brain to work normally. This is this pressure autoregulations. It means that in a normal brain, the pressure in the brain and the perfusion of the brain will stay constant when you have this mean arterial pressure that will be between 50 and 150. But you see that when you have a patient that is in hypovolemia and when you hypotensive, you see that the pressure, the perfusion of the brain is directly connected with the pressure and the mean arterial pressure. And so this is one of the explanations why when you have a patient in hypovolemia, you have these decreased mental states because of the decrease of the perfusion of the brain. And so this is why it's very important in our trauma patient to start with these 3 resuscitations. And the same when you have this hypertension, so when you have an increase of the mean arterial pressure, the perfusion of the brain will increase, and so the blood flow will increase, so the percentage of blood in the brain will increase, and so you can have an increase of intracranial volume, and so an increase in the intracranial pressure, and that's why in some patients with very severe hypertension, we can have these neuroscience. In traumatic brain injury, you can see that this relationship and these autoregulations disappear, and the brain is not able to maintain a good perfusion in the same kind of range, and it's able to maintain a good perfusion only in a range of between 90 and 110. And so that's why in traumatic brain injury, like mean arterial pressure is one of the goals. To maintain mean arterial pressure is one of the goals because it's directly connected to the perfusion of the brain. And so when you have this change, you have an increase of the intracranial volume. So if you have for trauma an increase of an hematoma, for example, or cerebral edema, you have this compensation that are starting to be involved. And at one point, it starts to be too much for the brain, and you have an increase of the intracranial volume, and you can see that the intracranial pressure is going up very fast. And so why it's not good to have this increase of the intracranial pressure? This is a very, very important relationship to remember. What we want in the brain is that this cerebral perfusion pressure, so this CPP, is constant because this cerebral perfusion pressure is directly linked to the blood flow. So it means that when you have a decrease on the CPP, you will have a decrease on the cerebral blood flow, and so your brain won't be perfused enough. And this cerebral perfusion pressure is equal to the mean arterial pressure minus the intracranial pressure. So if you start to do the math, you can see that when you have an increase of the intracranial pressure, you will have a decrease on the cerebral perfusion pressure, and so you will have a decrease of the cerebral blood flow, and so a decrease of the perfusion of your brain. And so that's why you will have these symptoms when you have an increase of intracranial pressure. So what are the symptoms and what you should look for when you have this increase of intracranial pressure? This is what we call the Cushing reflex. I'm sure that you already heard about this Cushing reflex. This Cushing reflex is linked to this relationship between the cerebral perfusion pressure, the mean arterial pressure, and the intracranial pressure. When you have a severe increase of intracranial pressure, the body will try to keep this CPP constant, and so you will have an increase of the mean arterial pressure. So you will have a patient with an increased mean arterial pressure, and because the baroreceptor will feel this increase of the mean arterial pressure, you will have a reflex bradycardia. And so when you will have a patient with increased intracranial pressure, you will have a patient with increased mean arterial pressure associated with bradycardia, which doesn't seems good when you have a trauma patient. Usually when you have a trauma patient, the patient is presented with hypovolemia, so hypotension, and he will have a tachycardia. So when you have a trauma patient that comes to the ICU, bradycardic and with hypertension, it should ring a bell in your head that it could be associated with an increase of intracranial pressure. All the respiratory centers are also in the brain, and so when you have this dysfunctional brain, you can have a change in the respiratory patterns. And so we will have what we call the chain stroke respirations. So this is a succession of bradypnea, apnea, tachypnea, and then apnea, and then tachypnea. So you have this dog that is breathing very fast, stop breathing, breathing very fast, stop breathing. This is also what we can find in in patients with a huge increase of intracranial pressure. And so it is a way we will recognize the traumatic brain injury patients. So first rule, when you want to know if your patient has a traumatic brain injury, it will be to evaluate your neurologic system after your initial resuscitations. So if you remember all the lecture that you already have, when you have a patient in hypovolemic shock, one of the clinical signs that is associated with hypovolemic shock is the presence of decreased mentation. So you can't evaluate correctly the mentation of your patients if your patient is not already correctly resuscitated. So and also when you have a patient with a head trauma, you can have, like hematoma in the head. You don't see anything, but this poor guy had exophthalmia and prolapse of the globe. And so you can't evaluate all the pupillary reflex in this kind of trauma. And also when you want to evaluate your patients, if you want to see if your patient can walk correctly, but if he has 2 or 3 limb fractures, he won't be able to walk. So you have to evaluate all your patients before being able to evaluate your neuro states. Again, so I'm not sure that you will see because it was a black dog, but it was the same kind of dog as the first video with this strange movement over the nose of the patients. And this patient was not working. And so even if we know that it could be just a fracture of the sinus, we had to follow our patient to be sure that it will improve with analgesia fluids and to be sure that it doesn't have any traumatic brain injury. So once you have resuscitated your patient, you will evaluate your neurostates, and when you have a traumatic brain injury, your patient will have abnormal neurosigns. And in particular, the signs that you should look for are the decreased mental states. And as I said, always after fluid resuscitation. So even after fluid resuscitation and normal cardiovascular system, you will have your patient that is still in lateral recurrency, non-responsive. And one of the signs that we often have when we have a patient with increased intracranial pressure, this is this head pressing. So you have the dog that is just pushing again the wall of his cage and non-responding very well. So this is one of the signs, neurosigns that you will be able to see. And this is also associated with systemic signs. As I said, you will find this Cushing reflex with the bradycardia and hypertension that is a trauma patient is not normal because it should be more tachycardic because he is in pain, he is in shock, and he should be hypotensive and not hypertensive. And you can have this association between the tachypnea, apnea, tachypnea in your patients. But usually chain stroke respiration, this is not something that we see very often. This is really in patients with a huge increase of intracranial pressure that we can see it. And so to help us to have a nice evaluation of the neurosystem, you have at your disposition this modified Glasgow-Coma scale. And this modified Glasgow-Coma scale will go through all the important things that you need to look at for the evaluation of your neurological patients. The first thing is, does my patient has motor activity, and how is motor activity? Does my patient has a normal gait? Is my patient is in lateral recurrency? Can he stand up? So this is all the kind of evaluation that you will have to do, and based on this, you can give a score. You will also evaluate the brainstem, and with this you will evaluate all the pupillary reflex. So this is where you will have to look at the eye and evaluate the pupillary reflex, put a very strong light in front of the eye of your patients, and see if you have a normal contractions of the pupils. And the last part is the level of consciousness, to see if your patient interacts correctly with you or not, if he can feel pain or not, and this is also a way to evaluate your patients. So for all motor activity, brainstem, level of consciousness, you can give a scores, and so you will be able to give a prognosis to the owner of your patients. So when you have a very low modified Glasgow Coma scales, the prognosis is usually not very good. And when you have increased modified Glasgow Coma scale, your prognosis is better. And it's also very interesting when you are working in a 24-hour facility, and so when you have these rotating teams, because you are able to give a score to your patients, and so this is a more objective evaluation of your patients, that, just if you say, he improved, he looked at me a little bit better, or he's able to walk or to stand up, this is really important to have this scoring system between your team to be able to follow your patients. It was shown once again that this modified Glasgow Coma scale was really associated with prognosis. So when you have this low modified Glasgow Coma scale, this is a worse prognosis, and it has been shown in several studies. So when you have your patient that come in the ICU with a trauma, first thing you have to do, this is to focus on your ABC and to stabilize your ABC. Remember that every head trauma is not always associated with traumatic brain injury. So even if you have a skull fracture, or skull fracture can be associated with traumatic brain injury, but jaw fractures, it's not always associated with this traumatic brain injury. Always evaluate your traumatic brain injury after the initial resuscitations. And also search for systemic and neurological abnormalities. So do your modified Glasgow Coma scales and repeat it, because your patients can, be better after a few hours, but can also crush. Because as I said, you can't do anything about the primary lesions, the primary traumatic brain injury, but you can, the secondary one you can have an evolution of the secondary brain lesions, and so this one you really have to follow your patient to be sure that there is no worsening of the condition of your patients. Then this is a treatment, so you already know this picture now, but we like to use it because you can recognize some person that are here. You have Chris, you have Amy, you have Sarah somewhere. Where is Sarah? I'm sure Sarah is here. Where is it? You have Cyril, and you have, with the glasses. Exactly, so with the glasses. And so this is where and so with this team, we will be able to make a good job. Treatment goals, start again to think about the physiopathology. What you want to do is to keep this CPP, so this cerebral perfusion pressure, to maintain it constant, because you want the brain to be correctly perfused. And so to do this, you will have to maintain the good mean arterial pressure. And if you have signs of increased cerebral pressure, you will have to decrease this intracranial pressure. So first, to do this, as I said, initial stabilization is very important. So as any kind of trauma patient, you will have to start with your ABCD. And so the neuro arrives and comes just after your ABC. So don't jump directly on the treatment of your traumatic brain injury. Start with your initial stabilizations. Just few words, so I won't go through the initial stabilization because we have seen it already, but just few things that will apply if you suspect a traumatic brain injury. Oxygen is super important because we said that hypoxemia will increase this secondary brain injury, so you have to decrease this hypoxemia. But just remember that you don't want to do anything that will increase the intracranial pressure in these patients. So maybe even if nasal oxygen, and so put a nasal catheter in the nares is very interesting to give oxygen to our patients. In a patient where you suspect traumatic brain injury, could not be the best option because I think that if you already put a nasal catheter in, you know that they are like, achoo! And doing this, it's really increased the intracranial pressure very fast and very much. And so you don't want your patient to do this. So in the patient in which you suspect to have an increased intracranial pressure, don't use nasal catheter for oxygen supplements. Maybe choose flow-by, mask, or oxygen cage in this patient just to avoid them to, I don't know how we say it in English, achoo. Thank you. Ventilation is also important because CO2 in the brain can change, can do vasoconstriction or vasodilation, so it will change your cerebral perfusion pressure. So it's important in this patient to check for CO2, to make a blood gas. We don't do it very often, but in humans, in this very severe traumatic brain injury, they will anesthetize, intubate them, and ventilate them to be sure that they keep the PCO2 in the normal range, or maybe increase or decrease based on what they have in the intracranial pressure. And analgesia also is very important once again in the trauma patients. But when you will have to choose your molecules, maybe think about the fact that morphine can induce vomiting. And once again, when you vomit, you increase your intracranial pressure very fast and in a very big manner. So maybe go away from morphine in this patient because you can induce this vomiting in these patients. So initial stabilization for traumatic brain injury is quite the same as for any patient, but just remember, avoid nasal catheter and maybe avoid morphine in this patient, if you have other options, because analgesia is very important. Then we have fluids. So how do we with fluids in these traumatic brain injury patients? With fluids, we have two objectives. The first one is to restore the IV volumes, and the second one will be to decrease with our fluids the intracranial pressure. You have a very nice review that is quite new in Frontiers, and this is open access, so you can have access to it from anywhere. That review all the data that we have concerning the fluid therapy in the traumatic brain injury patients. So I took all the information from this paper, and if you want to go deeper, you can have a look at this paper. So first objective of the fluid therapy in traumatic brain injury is to restore the IV volume, because I remind you that in this traumatic brain, the brain is not able to maintain a correct blood flow in hypotensive patients. And so it can just maintain a normal blood flow between 90 and 110 millimeter of mercury of mean arterial pressure. And so the cerebral flow and the cerebral perfusion pressure is directly linked and correlated with the mean arterial pressure in your patient with traumatic brain injury. And so that's why it's super important to maintain a normal mean arterial pressure in these patients. So once again, the first line fluid that we will use are isotonic crystalloids, but you can use other kind of fluids like hypertonic crystalloids, and we will see how to choose between the two of them. You can use packed red blood cells or plasma transfusion if you have a patient that is bleeding. And if your patient doesn't respond to your fluids, you may add vasopressor quite quickly in this patient to really maintain a normal mean arterial pressures. And the target of this pressure in traumatic brain injury is between 90 and 110, because this is the range where the brain is able to have a normal perfusions, and so that's why we try to have this mean arterial pressure target. Second objective of the fluid therapy is to decrease the intracranial pressure, and as you can see, when you have always remember that water can move freely between all the compartments of the body, and water will go all the time from the compartment that is the less concentrated to the compartment that is the most concentrated in small molecules, and especially in sodium. And so that's why we will use this hypertonic saline in our patients, because we want to have this, So that's why we will use this hyperosmolar therapy. And so for hyperosmolar therapy, you have two types of fluids. You have this hypertonic saline, and you have the mannitol. And so the idea of this hyperosmolar therapy is that you will increase the osmolarity of your IV compartments. And so the extra fluid that is in the neuron will come back in the IV compartments. And so you will be able to decrease the cerebral edema, and so to decrease the size of the brain, and so to decrease the intracranial pressure. So as I said, you have two options for this hyperosmolar therapy. You have the mannitol. The mannitol is a sugar that is, as you can see, very hyperosmolar. So a normal osmolarity in the patient is around 300 milliosmol per liter. So you can imagine that when you add in the IV compartment fluid that is really hyperosmotic, the fluid will go from the cells to the IV compartment, and so this is the way it will decrease the edema. So I put here the dose that we are usually using. It lasts between 2 and 5 hours, and you have a list of advantages of the mannitol. So on the top of the hyperosmolar activity, it also decreases the blood viscosity, so the perfusion will be better in the brain. It decreases the CSF production, so as you have an increase of the size of the brain, you want to decrease the size of the brain, but decreasing the CSF production will also decrease the intracranial pressure by decreasing the volume of the CSF. There is some question about the fact that mannitol can increase the bleeding in the brain. And so that's why sometimes when we think that the TBI is associated with an hematoma, we may be reluctant to use mannitol. I don't know how you use it, but when we have clear signs of increased ICP and traumatic brain injury, we use mannitol because we don't have access very easy to CT or MRI, or the patient is not stable enough to go directly in the CT and MRI, so we try with mannitol, and so we don't have this kind of data in the vet world. The other option that you have, this is the hypertonic saline. So hypertonic saline, this is a fluid with a lot of sodium inside, and as there is a lot of sodium in the fluids, it will increase the osmolarity of the IV compartments, and so it will really aspirate the fluid that is in the neurons. You will use it at 4 to 6 ml per kilo IV over 10 to 15 minutes. You have to be sure that your patient is not hypernatremic before giving hypertonic saline. And once again, it's great because this hypertonic saline will also increase the mean arterial pressure. This is one of the fluids that we use with crystalloids to increase the mean arterial pressure. And as in traumatic brain injury, the perfusion of the brain is really linked to the mean arterial pressure. It's a good way to have this increase of mean arterial pressure. But just think that most of the time we can use it maybe once or twice because it really increases natremia a lot, and then you will have an hypernatremia that can be detrimental too. So how we do the difference, how we choose between the two in the clinical practice? What we do most of the time is that when we have we have the trauma patients came in the ICU, we start with crystalloids to increase the volemia. And then when we have a patient that is normovolemic but still have signs of increase of intracanal pressure, we will choose mannitol for this hyperosmotic agent. And when we have a patient that is still hypotensive and with signs of clear traumatic brain injury, we will go more for hypertonic saline because we know that it will increase the mean arterial pressure at the same time that it will suck the fluids in the neurons to put it back in the IV compartment. So increase ICP with hypotension, you will choose hypertonic saline, and increase ICP with a patient that is normovolemic, we will go more for mannitol. Do we have to give to our patient more treatment on the top of oxygen, analgesia, fluids, and this hyperosmotic treatment? Furosemide, corticosteroids, it's always a question. The answer is very easy. It's no for both of the drugs. It's contraindicated. There is a lot of protocol that describe the use of mannitol associated with furosemide because mannitol is a diuretic. So the idea is that if you use mannitol with furosemide, you increase this action of diuresis, so you increase the loss of fluids. But just think that in traumatic brain injury, you have a patient that is traumatized, so you have a patient that doesn't like hypovolemia. So if you give lots of diuretics, you will increase this hypovolemia, and so you will decrease the cerebral perfusion pressure, you will decrease the cerebral blood flow, and the brain won't like it. And so that's why in traumatic brain injury, we always use only mannitol and not the association with mannitol and furosemide. In other situations of increase of intracanal pressure, it can be discussed, like if you have a dog with a brain tumor that is very stable, maybe you can use both of them, but in trauma, furosemide is really contraindicated. Corticosteroids, we say it several times, but I say it again, it's not indicated in the trauma patients, and in the traumatic brain injury patients, it was one of the first kind of trauma patients where we had publication saying that corticosteroids were bad. Because in this traumatic brain injury, we know that hyperglycemia is very bad, and corticosteroids increase glycemia, and really the use of corticosteroids in dogs and cats that has traumatic brain injury is associated with a worse prognosis. So don't use corticosteroids in these patients. Then anti-epileptic drugs. So there is a lot of damage in the brain. So the brain can induce, so I said that most of the neuroscience that we have are a decrease of consciousness, head freezing, but you can also have some seizures. And so there is not a lot of consensus about the use of anti-epileptic drugs in these traumatic brain injury patients. There is no consensus for the use of prophylactic anti-epileptic drugs. So it means that when you have a patient with traumatic brain injury that is not seizuring, like we don't really know if this is good to add some anti-epileptic drugs or no in these patients. But what is sure is that when you have a patient with TBI that is seizuring in your ICU, you have to give him anti-epileptic drugs. And so when we have these seizures, we start with benzodiazepine, most of the time as a bolus, and then with a CRI. And you can choose between levetiracetam or phenobarbital. There is no consensus between which drug you can use, but you have to use anti-epileptic drugs if your TBI patients shows some seizures during hospitalizations. For the duration of the treatments, once again, no consensus. Most of the time, this is several months. Some dogs or cats may need this treatment for life. So this is really the evolution of your patient that will tell you if you can discontinue the drug or if you have to continue it for the life of your patients. Then nursing care is also very important for these TBI patients because most of the time when you have a severe TBI, your patient will be hypovigilance, so it will stay in lateral recurrency. And so all the tender loving care that Amy mentioned are super important in this patient because they have this decreased mentation, and so you have to stimulate them very much to be sure that they can interact again with what's happened around them. And you also have to be sure that you don't do anything that will increase the intracranial pressure. So the kind of easy thing that you can do is that you need to have an elevation of the head of your patient. So it means that you will have to put your patient on something. So the head is 30 degrees higher than the rest of the body. So this is very important because it will physically make the blood flow to go in the body and not in the brain. So be sure that your patient doesn't have the head that is lying down. And also avoid everything that is sneezing, I know the word, vomiting, and jugular puncture. So this, in your patient with a traumatic brain injury, don't take the blood on the jugular because anytime you just make your compression on the jugular, it will increase the intracranial pressure. So this is very easy to do, but it's sometimes in unstable patients, some small thing that will save the life of your patients. Avoid everything that will increase the glucose in your blood. And as I said, nursing care are very, very important, and especially make the owner of the patient come in the ICU to improve the interaction. Put your patient, even if it seems not to react to anything, put your patient outside so he can hear the birds, feel the winds, and this is very easy thing that will improve and make the recovery of your traumatic brain injury patients be faster. Surgery. So surgery, it's a cool thing to do on traumatic brain injury, but we don't do it very often because most of the time there is no indication for surgery. So the way we do it, but I think could be a long discussion about this, or our patient is deteriorating despite the treatments. And so this is the kind of patient that we will send to CT or MRI to see if there is something that we can treat with surgery. Or if we have a patient with TBI that has very localized neuroscience. So because of this, we think that he may have an hematoma really localized in the cortex or in this part of the brain, and so maybe we can do a surgery to remove this hematoma. But when we have a patient with loss of consciousness, we most of the time think that this is a cerebral edema, so we won't be able to do anything with surgery. So it's always pro and cons, how my patient is going, and can he go to have a general anesthesia for surgery and for imaging. But we had this kind of very good case with hematoma, and we went to surgery and we removed the hematoma, and the patient was really better, very quicker than if we didn't go to surgery. Prognosis, the main idea that I want to give you is that the prognosis of TBI is good if you let time to your patients. And this is very hard sometimes because the patients are very bad when they come in the ICU. And so it can be a long hospitalization. It could be a long recovery. So you have to explain it to the owner that it can take weeks, months before having a pet that is able to do what he wants. And so the owner needs to be convinced of this and wants to go through everything. But you don't have any idea at admission of the speed of the evolution of the patients. So I remember my first TBI patient, he had a big table that failed in the head. It was a small bichon. And he arrived in the ICU all bleeding with the skull totally broken, and like this. And after just few days, he started to be better. And after just few, maybe it was 10 days, something like this, he was able to walk and to eat. Maybe not totally normal, but he was able to have a good life for a pet. And so it's very, very important to give time to these traumatic brain injury patients. It takes time, and you don't have anything that you can, you don't, like, it's very complicated to be sure that this TBI patient won't do better and the other one will do better at admission. And so it's important to give time to your patients. Just remember that dogs and cats don't need to speak, don't need to read, and so they don't need to have the perfect brains to have a normal life. And so that's why it's important to just give them time. And so for the traumatic brain injury patients, it's important to be able to have an early recognition of this TBI, important of initial stabilization, oxygen-free analgesia, osmolar therapy with or mannitol or hypertonic saline, nursing care, super important, and really let them time for recovery. Thank you very much, and if you have any questions. No questions? It's coffee break, I think. Okay, thank you very much.